Transplant and Immunology, presented by Dr. Dori Segev, Professor of Surgery, Biostatistics, and Epidemiology, Johns Hopkins University, Baltimore, Maryland. Please give a warm welcome to Dr. Segev.
Good morning. So apparently there's also like a suicide prevention workshop or something going on here, and they gave me the wrong packet when I checked in last night. I thought maybe they were sending me a message. I was like, no, I'm in a field worse than suicide. I'm in transplant surgery. Maybe they thought we can finally give him an easy way out. So you're stuck with me for the next 4 hours. And what we'll do is we'll just go through all the topics sort of in however much time it takes each topic to do, and you can take breaks whenever. We can decide together when you want to take breaks. And there should be plenty of time for questions. I can answer to the best of my ability any questions you have. I will try to give you a sense of, so as you know, there's sort of the real world and then the world according to the boards. And so I'll try to give you my sense of maybe this was what they would be looking for, this is what they would answer, et cetera. I bet if I had to go back now and take the board's questions for like transplant or things I actually know, I would probably miss them all because like you know more than the examiners know. So we'll try to like keep things simple in the eyes of the examiners as well. So let's get on to it. These are my conflicts, my financial conflicts of interest, and if anyone knows of any other potential financial conflicts of interest, I work at an academic medical center, so I would welcome them. So this is what we're going to talk about: the immune system and rejection, immunosuppression and side effects, general indications and contraindications to transplants, recovery, allocation, policy, ethics, management of post-transplant stuff, infections, malignancy, live donation, dialysis access. Now, again, it would take me like a year, it's called a fellowship, to tell you like what I want to tell you about transplantation. But I've picked some things from CSAP and from board review and things that seem like they would be askable. So in the immune system and in rejection, we'll start with what is the best treatment for hyperacute rejection: plasmapheresis, rituximab, splenectomy, prevention, thymoglobulin. So prevention, good. If you chose anything other than prevention, you might get yourself into some trouble because hyperacute rejection is untreatable. This is literally, I put in an incompatible organ into somebody, and right there in the operating room, I watched the thing completely die. Two types of cells that make up the immune system: lymphoid and myeloid. And you're probably thinking, I can't believe we're going to talk about these things. But, the board's people, that's how they are. The lymphoid cells, that's the B cells, the T cells, and the NK cells. So B cells, these are plasma cells or memory cells. They're the only cells that produce antibodies. So think B cell, antibody. T cell, these are either the helper CD4 class 2 T cells or the cytotoxic T cells. And these are part of the HLA response, the MHC response. So B cell, antibody, T cell, HLA response. And this is sort of rejection. When you hear garden variety rejection in transplantation, it's T cell mediated. And then there's the natural killer cells. The myeloids, that's the neutrophils, eosinophils, basophils, mast cells. These are the ones producing histamine, IgE. That's the allergen response. And then the monocytes, that's either the dendritic cells, they're involved in antigen presentation, or the macrophage is involved in phagocytosis. Again, these are really simplified views of what goes on, but they like to ask simple things. Hyperacute rejection, you messed up. This is preformed antibodies, and the only way to treat this is to avoid this. Acute rejection, That's either cellular. Remember, we said T-cell mediated, and we'll talk in much more detail about that because that's the kind of rejection we talk about the most in transplantation, unlike the kind of rejections that I faced in high school. Those were not humoral. So that was bad. So humoral is B-cell antibody-mediated rejection. We call it AMR in transplantation. These can be treated by plasmapheresis, IVIG, rituximab, which is an anti-CD20 anti-B-cell antibody. It's unlikely they're going to go down the road of AMR because we hardly understand AMR, so they probably don't understand it at all. But those three buzzwords should get you through it. So if there's a plasmapheresis or rituximab answer there, that's probably what they're looking for antibody-mediated rejection. Chronic rejection, this is a fibrotic process. There's a new concept of chronic antibody-mediated rejection. Don't worry too much about chronic rejection. These are not well understood at all and probably won't be asked too much. Let's talk a little bit about immunosuppression agents and their side effects because these are definitely askable and there are some classic questions here, so you need to know the classic answers. What's the immunosuppression agent classically associated with seizures and tremors? Prednisone, FK506 tacrolimus, MMF, mycophenolate, antithymocyte globulin, sirolimus rapamycin. I'll try and come up with different songs for each. It might be a long morning, though. All right. Yeah, good. Got a good crew here. You've rotated on transplant sometime recently. Immunosuppression agent classically associated with poor wound healing. Same possible responses. I should start singing like Prince songs or something. Oh, okay. Well, so everyone who gets a transplant gets prednisone. So if it were really associated with poor wound healing, none of our patients would heal their wounds. But they do, not just because we're perfect, but because prednisone, not so much. Rapamycin, you put them on rapamycin in the first month post-transplant, you might as well put a vac on that wound. So that's a thing to remember. Immunosuppression that requires pre-medication to minimize the risk of cytokine release syndrome. Same answers. Close, kinda close. It's thymo, and we'll talk about that. All right, so in terms of immunosuppression, there's three roles of these agents. One is induction, one is maintenance, and one is treatment of rejection. Induction, that's like given in the first week, and that's to totally blitzkrieg the immune system so that you can get sort of early engraftment. Maintenance immunosuppression is for life, and that's to make sure that they don't, get sort of these late rejections. And then treatment of rejection, obviously. Old school maintenance was azathioprine and prednisone. If you see patients that are on azathioprine and prednisone, they were probably transplanted a while ago, and they don't like to mess with things. In the 80s, they added cyclosporin. This was huge for transplantation. This really was the first thing that brought rejection rates down to something that was tolerable. So cyclosporin, aza, and prednisone was the thing in the 80s, the first time Madonna was popular. In the 90s, FK tacrolimus replaced cyclosporin, MMF replaced azathioprine, and today that's still sort of standard triples. If you hear that somebody's on triples, they're on FK, MMF, and prednisone. This is a very simple view of the T-cell response to an allograft, and I kind of say that jokingly, but it really is a simplified view of it. You have an antigen-presenting cell that presents antigen to the T-cell, And then there's this first signal, which is through CD3, and you can block that. And then there's this T cell receptor and the downstream pathways that happen there. And then those send things back off for a second signal that's a co-stimulation signal, as well as this IL-2, this CD25 kind of secondary response. That's sort of a positive feedback loop, and that activates this cute little molecule called target of rapamycin. So you might guess how that can be blocked, and then that stimulates the cell cycle and stimulates replication of the T cells so they can make more T cells to further the attack. So that's kind of the overview of how things happen. Now, obviously, you want to know your agents that you're going to be asked about, where they act in this overview. Steroids are induction agents, they're maintenance, and they're for treatment of rejection. You know the toxicities of steroids. It's all that bad stuff that happens when you give steroids, and I'm not going to go into those details. Classically, people think of steroids as acting down here on this NF-AT pathway, blocking AP1, blocking this thing that then creates IL-2, etc. But really, in reality, steroids act everywhere. And I doubt they will ask you which part of the pathway steroids act, because it's not kind of a classic question. Calcineurin inhibitors, on the other hand, they will ask you because they inhibit the calcineurin pathway, and so that's pretty askable. These are mostly maintenance agents. On occasion, if somebody's on a calcineurin inhibitor and they have a mild rejection, you can boost the level of their CNI. But in general, these are maintenance immunosuppressions. There's tacrolimus, FK506, and then there's that old one, cyclosporin. And these are dosed by levels. That's another good thing to know about them. And you keep the FK levels somewhere between 5 and 15, usually higher initially post-op, lower for later post-op, and cyclosporin the same way. And they act here, so you have this T cell receptor that activates calcineurin, which then activates these downstream pathways. And if you block calcineurin, you block those downstream pathways. The toxicity in general for the CNIs are renal toxicity, ironically. So we give kidney transplant patients calcineurin inhibitors, which then get calcineurin inhibitor toxicity, hyperkalemia, hyperglycemia, hypertension. Cyclosporin has weird toxicities of gingival hypertrophy and hirsutism. Again, the reason I bring up these things is that these are kind of the classically weird things that people like to ask about. The toxicity with FK, as you all knew, was neurotoxicity, so tremors and seizures. And very often we will see somebody in post-op clinic who can't sign their name because they're having these tremors. And we're like, I don't even need to check your FK level. I know it's high. Antiproliferatives, so this is MMF and azathioprine. These are maintenance agents, and they act down here on this sort of secondary pathway that activates the cell cycle. So they keep the T cells from replicating when the T cells have decided to act on something. MMF blocks the de novo purine synthesis pathway, which I'll talk a little bit about, and azathioprine blocks this cell cycle. The toxicities are the penias, as you might imagine, classically leukopenia with MMF and just pancytopenia with azathioprine. And these are real. You'll see people's counts drop way, way down. Interesting toxicity for MMF is that it blocks this de novo purine synthesis pathway, and as I'm sure you remember like it was yesterday, because for most of you it's kind of like it was yesterday, there is that salvage purine pathway as well. And so the cells that have the salvage purine pathway aren't going to be affected by MMF, but the ones that lack it happen to be B cells and T cells, which is awesome, and also happen to be enterocytes, which is not awesome. So if you're taking MMF, you get GI toxicity like nausea, vomiting, diarrhea, as well as the leukopenia. So basically, people's enterocytes can entirely slough off, and that's not pleasant at all. Rapamycin, or sirolimus, blocks, as you might imagine, the target of rapamycin, or TOR. These are also maintenance agents, but they're typically maintenance agents that we try to start later in the process, particularly for people who we think might have wound issues. Toxicity is neutropenia, as one might guess from the mechanism of action, but also this major wound healing thing. So again, you start an obese recipient, who got a liver transplant on RAPA, that wound will not heal. ATG, anti-thymocyte globulin, referred by brand as Thymo in the transplant world, is mostly an induction agent, which is funny because it's not approved for induction. It's not FDA labeled for induction. It's only FDA labeled for treatment of rejection. But more than half of the kidney transplants in the U.S. get this agent as an induction agent, and it blocks this CD3 part of the T-cell receptor. And what it does is it constitutively activates the T-cell receptor, so the T-cells go totally nuts and then they explode. And all that stuff that's inside the T-cell then starts to float around in the blood and cause this cytokine release syndrome, which is ugly. And every once in a while, usually like every July, we'll have some clueless fellow join our service and forget about this and start somebody on this agent for rejection. And then the person, you walk in the next morning and the patient's in the ICU, intubated. What the hell happened? Oh, they forgot to give the pre-meds. And so the patient had this fever, rigors, wheezing, dyspnea, ARDS-like syndrome. You need to pre-treat with steroids and Tylenol and Benadryl, and then that never happened. So that's ATG. The toxicity is leukopenia, as you might guess, because it's exploding T cells. There's this old one called OKT3, which we used to nickname not so OKT3, because this also, it's like ATG, but it's like a monster version of ATG. It's an anti-rejection treatment. It's sort of when you have no other options available to you. And the toxicity is just like ATG, but on a monster level. So you can really send somebody to the ICU with this guy. And when I was training, we used a lot of it, and wow, that got ugly. And also this classic toxicity of aseptic meningitis that they could ask about. There are IL-2 receptor inhibitors, daclizumab, basiliximab. Daclizumab is now off the market, but probably a change recent enough that the board writers don't know about it, so they may just consider the two of them basically the same agent. These block the IL-2 receptor, so they block this entire sort of secondary positive feedback mechanism here. And they're induction agents, and they're pretty benign, actually. There aren't really classic toxicities associated with them. So that's that. Let's talk about indications and contraindications for transplantation. And you need to know it basically like one step beyond the indication for a kidney transplant is kidney failure, and the indication for a liver transplant is liver failure. Although that's really the answer. But you should probably know one step more for that. So for kidney, the top two things we transplant for are diabetes and hypertension. So again, these are the top two causes of ESRD in the United States. Liver, now the top cause is Hep C, also alcoholic liver disease, but coming very quickly on the landscape is what they nicely call NAFLD, non-alcoholic fatty liver disease. The boards might refer to it as NASH, even though it's not called NASH anymore. That was non-alcoholic steatohepatitis. But it's basically fatty liver disease. And why is it emerging as an indication for liver transplantation? Well, Hep C is being treated more and certainly diagnosed more, and so the incidence of Hep C is dropping off. But NAFLD comes from morbid obesity, and we certainly have a lot of that in the United States. So probably within a few years, NAFLD will be the top indication for a liver transplant. Pancreas is interesting, right? You're doing a pancreas transplant for diabetes, but you're doing it for either end organ complications of diabetes or for this weird thing called hypoglycemic unawareness. How many people have ever met a patient with hypoglycemic unawareness? These are interesting people. Like, they can't even drive because they get hypoglycemic, and then they run their car into a tree because they're not aware that they're hypoglycemic, and all of a sudden they pass out. So that's not good, and that's not a good lifestyle for people. And so those are people who get solitary pancreas transplants. If somebody has diabetes and kidney failure, then a simultaneous kidney pancreas transplant is the best thing for them. And the pancreata do the best when they're transplanted in that context. Intestinal transplants, this is sort of a weird, not particularly common transplant. Probably a handful of centers in the country do this. These are done for refractory intestinal failure or for severe complications of TPN for somebody who has like short gut, et cetera. You probably don't need to know more than that about intestinal. Contraindications, general contraindications for abdominal transplants. One is malignancy. So we don't want to take somebody who 6 months ago had a bad malignancy. We managed to excise it, but we're worried about a recurrence, and then we blast their immune system, and all of a sudden they get a bad recurrence. So malignancy, recent malignancy is a contraindication. There is, once you consider them cured, there is sort of a waiting period that depends on the disease process and the severity of the disease that they had, and that's there's no sort of good answer for that. But you need to know that there's some waiting period. There's exception, hepatocellular carcinoma in liver transplant. We actually transplant for this because if you take out the liver, you take out the entirety of the disease, provided it's not metastasized. And then renal cell carcinoma, same deal in kidney. Other general contraindications, like things we wouldn't want to operate on somebody for. So if they have major cardiovascular risk, you don't want to do a big whack on them. Active substance abuse, that's sort of the classic textbook answer. You know, if somebody smokes weed on occasion, is that substance abuse? I don't even, the term substance abuse is weird to me. I imagine them like looking at a bong and just like beating up on the bong. They're abusing their substance, right? I mean, it's really recreational drug use, right? And it kind of, the reasons against transplanting people who have active recreational drug use is that they say that it's associated also with non-adherence to immunosuppression and things like that. Non-adherence is a major problem, and if you think that somebody's not going to take their immunosuppressants, that's a bad problem, and you wouldn't transplant them for that. There's also some weird stuff like people who smoke weed. There's like a risk of like aspergillus and other things associated with the marijuana. But apparently, one of my ID friends tells me that if you microwave the marijuana and then you smoke it, you're all good. So I don't know. I bought a microwave. That's all I can say. But not for that, because I don't live in California. Lack of vascular conduit. So you got to sew the thing in somewhere. And if there's like crud all over all of the arteries in the abdomen, you might have a hard time finding a place to sew it in. Active serious infection. So oftentimes somebody sits on our waiting list for a couple of years and comes in and has got like a really bad active infection. They're not going to get a transplant on that day. An active minor infection, like some toe fungus thing, that's probably fine. HIV used to be a contraindication for transplantation. It has not been a contraindication long enough that if they ask you on the boards, can you transplant somebody who has HIV, you can say yes. And in fact, just recently, we also made HIV not a contraindication to donation, but I don't know if they're going to ask you about that because that's pretty recent. But we certainly transplant people who have HIV. Just some little tidbits about recovery, allocation, policy, ethics, etc. Which of the following, this does not belong here. Let's do this later. I don't know how this got here. Well, let's do it now, and then we'll talk about it later. Which of the following is true about PTLD? 1, it's commonly a T-cell variety. 2, it's commonly a Hodgkin's tumor. C, can be treated with rituximab. D, associated with HSV-8. E, usually seen 1 year or more after transplantation. Which of all of those lies is actually true? Yeah, pretty good, but kind of split. The room wins, but 67% don't win. This is like how Trump is going to win the election. But that's, I don't know why that question got put there, because we'll talk about that a little bit later. So remember that in the back of your minds that you didn't know the answer to that. How are organs recovered in the United States? They're recovered through organ procurement organizations. Okay, so if there's a death at any hospital in the U.S., they are required to call the OPO. Now, do they always call the OPO? I mean, if they forget, they forget. But they're supposed to call the OPO and notify them about every death. And then the OPO evaluates, these are in-hospital deaths, and the OPO evaluates that death for donor suitability. The OPO approaches the family for consent for donation, not the docs taking care of the patient. They evaluate the donor, they evaluate the organs, they get all the information they need about it to make organ offers. They manage the donor and recover the organ. So once the donor is dead, if they're brain dead and they're still in the ICU being sort of supported, the OPO takes over management of that patient. And then they arrange the recovery of the organs and they distribute them for transplantation. So they're important. One thing that is known is that uncoupling the notification of brain death, i.e. the docs telling the family, sorry, your loved one is dead, from the request for donations, i.e. the OPO coming in and saying, hey, sorry that we heard this news, but do you want your loved one to have a living legacy? That increases consent rates. So they don't want the doc to say, you know, your loved one is dead. By the way, can we have the organs? Because that doesn't sound great. The other thing to know, but that they could ask you about that. That's like CSAP worthy. The other thing to know is that donor management. So once a person's brain dead, the management of that donor is directed at maintaining organ perfusion. So maintaining perfusion to the organs that you might want to transplant. Again, kind of self-evident. Both of these things are self-evident, but you'll find them like in the context of one of these questions, like which is false or true about the organ recovery process, and they'll have a whole bunch of weird stuff. And by the time you get to this, your brain is so confused that you're like, is that true or is that not true? You know these two things, they're true. There are two types of donors, basically. There's brain dead, or what we call donation after brain death. And that's, you have to go through the brain death exam, so the apnea, and prove there's no cerebral blood flow, and do the cold calorics and all that other stuff. And then there's cardiac death, what they used to call non-heart beating donors, what we call now donation after circulatory arrest or something like that. We still call them DCDs, donors after cardiac death. This is somebody who's basically, unsavable, and you're going to extubate them and let them pass. And you say, hey, if we extubate and they die very quickly, they have a cardiac death very quickly, can we take the organs? And this is a weird process. How many of you have seen a DCD donor? Okay, so you know what I'm talking about. You extubate. You either do it in the OR pre-room or in the OR itself, or some centers, some hospitals require you to do it in the ICU, and then they have this sustained asystole, which is confirmed by the intensivist as, okay, they signed the death certificate, and then you rush in, you prep everything in like 5 seconds, and you actually rush into the belly and you flush. And then once you flush, then everything is cold and preserved and you can slowly remove the organs. But it's important to remember that this is some degree of sustained asystole, and it's different from hospital to hospital. And they need to be declared dead by the intensivist. So until they're dead, you don't touch them. And so that goes for brain death and DCD. The transplant team has nothing to do with the donors, don't make any medical decisions about the donors. They don't interact with the family until the donor is declared dead. There was a story about a decade ago or so of a fellow who went to go do a DCD, and this was one of those DCDs that they were doing in the operating room. So they extubated, and they're watching the vitals kind of painfully, slowly deteriorate, knowing that, if it accelerated, it would be great for the organs, and if it continued at this slow pace, then it wouldn't be great. And the intensivist asked the fellow, hey, what do you think we should do? And the fellow advised giving a huge slug of morphine, which the fellow should not have been doing. And the intensivist gave it, and the patient died more quickly, obviously. And one of the nurses in the room was horrified by this whole thing, because that whole hospital had never really done a DCD before. And that's why the intensivist was being naive and asking this question. And the fellow, as a fellow, has probably done like 4. And so the fellow was being naive as well. And anyway, this guy almost got put in jail for this, because it's like assault, because he had nothing to do with the donor until the donor's dead. Once the donor's dead, then the transplant team can take over. So important thing to know. Allocation in this country is done through the Organ Procurement and Transplantation Network, the OPTN, which happens to be run by a group in Richmond, Virginia called the United Network for Organ Sharing, or UNOS. And if you hear OPTN, you hear UNOS. These are interchangeable. Technically, it should be referred to as the OPTN. Colloquially, everyone refers to it as UNOS, and I could even see the boards referring to it as UNOS. So UNOS is a group of professionals, some transplant providers, and some lay people, and they decide and enforce allocation rules in the United States. And when we talk about ethics, we'll talk about sort of the ethical dilemma of transplantation and our involvement in deciding who lives and who dies. And UNOS has a bunch of committees. They have a kidney committee, liver committee, et cetera. And these are transplant professionals, government liaisons, patients, previous donors, live donors, et cetera. The priorities for allocation are different by organ, okay? And I'm not going to talk about the thoracics, because I doubt you'll get asked about the thoracics, because we're general surgeons. But the abdominal organs, kidneys are basically allocated by waiting time. There are some bonuses for vulnerable populations, like kids get some bonuses, HLA-sensitized patients get some bonuses, because otherwise they have to wait a very long time. And there's a recent change, like a year ago, change to the kidney allocation system, where the top 20% quality kidneys are now prioritized to the top 20% quality recipients. So you measure a kidney by how long you think that kidney is going to last. You measure the recipient by how long you think they're going to last. And the top organs are now prioritized to the top recipients. Again, this is a recent change. I doubt they'll ask for it. It's still 80% of the kidney waiting list is still allocated as the biggest queue on the planet, 100,000 people waiting in line for who becomes next available for a kidney. And so in general, waiting time is still the primary mode by which kidneys are allocated. Pancreas is allocated basically like kidney without the top 20% thing. So again, just remember kidney and pancreas, mostly you wait in line. Liver is totally different. Liver is allocated by the Model for End-Stage Liver Disease, or MELD, and this is the predicted death in the next 90 days. Okay, this was not modeled in pre-transplant patients. This is modeled like a long time ago in like people who received TIPS or something like that. I can't remember that population. But basically, if you have cirrhosis, what is your probability of dying in the next 90 days? It's a combination of INR, bilirubin, and creatinine. And the higher a chance you have of dying, the higher priority you have for a liver. There's some bonuses. So there's some conditions that aren't well captured by MELD, like fulminant hepatic failure, HCC, right? Because with HCC, you've got a tumor. Otherwise, you look pretty good. Then your tumor grows, and then your tumor gets too big, and we can't transplant you, and then you die. And so there's this weird thing, and we give bonuses for HCC, and we give bonuses for other conditions as well, and people kind of have to apply for those bonuses. But in general, It's what we jokingly call lifeboat medicine, right? So you're like rowing your boat around the sea of people with cirrhosis, and you find the person who's about to die, and you throw them into your boat, and you transplant them, and then you throw them back into the sea, and you row your boat around. You find the next person who's about to die, and you transplant them, etc. So if you remember that bizarre image, you'll at least remember allocation priority for liver. Patients with HCC get bonus points if they're within the Milan criteria. Okay, and this is like a study that came out of the Milan. And these are basically T2 lesions. Okay, so the rule is 1 lesion greater than 2, less than 5 centimeters in largest dimension. 2 or 3 lesions, all less than 3 centimeters, no extrahepatic disease, no gross portal or hepatic vein involvement. Now, there's always discussion in the transplant community and tiny little tweaks to what happens with people with HCC. But I think if they ask you anything, it's this, because it's like such a classic criteria that's used for liver transplants. The hierarchy for allocation is local. So there are like 58 OPOs, and they cover an area, and they have hospitals associated with them. So in Maryland, there's the Maryland OPO, and Hopkins and the University of Maryland are part of that OPO. And then they cover all of the area hospitals that are within that geography where donors could come from, but there are only 2 transplant centers in that OPO. So anything that comes from Maryland, we get the 2 centers in Maryland get the highest priority for, and then it goes regional and it goes national. Now there are some skips, and so, for example, if there's a sensitized patient and there's a 0 HLA mismatch offer, that could skip local and even go regional or national. So there are all sorts of little nuances, and if I showed you the slide of the current kidney allocation system, you would like pee yourself because it's kidney, but also because like it's so strange and confusing. So I'm trying to give you just some general things to put in your mind because you have 9 million other facts to cram into your heads before this test. So remember, there are a little bit of skips, but in general, it's this sort of local, regional, national thing. Some policy and ethics stuff. Let's talk about various levels of legality and comfort in the transplant world. So what's organ trafficking? And I'm just going to read you this definition because it's an important definition to be aware of. This is recruitment, transport, transfer, harboring, or receipt of persons by means of threat or use of force or other forms of coercion, of abduction, of fraud, of deception, of the abuse of power, of a position of vulnerability, of the giving or receiving of payments or benefits to achieve the consent of a person having control over another person for the purpose of exploitation by the removal of organs, tissues, or cells for transplantation. That's illegal. That's also very broad. So trafficking is not necessarily kidnapping somebody, putting a gun to their head, and then stealing their kidney. Trafficking can be a lot of much more subtle coercion, and that goes on a lot across the world in transplantation. All of that is illegal. Transplant tourism, on the other hand, is not illegal necessarily. This is the purchase of a transplant organ abroad that includes access to an organ while bypassing laws, rules, or processes of any or all countries involved. So if you go to Africa and you purchase an organ there, you are violating the laws of the United States, which say you can't purchase organs. And so that's considered transplant tourism. You may not be violating the laws of Africa or India or China or wherever this happens, but you're violating the U.S. laws, and so we would consider that transplant tourism. This is not accepted by the transplant community, although this happens. People get super desperate. They need a transplant. They go to India. They buy a transplant. The donor and recipient traveling from a country with no transplant services to a country with transplant services is not tourism. Okay, so if somebody, there's a lot of really good transplant centers in India, and there are a lot of countries in Africa that either don't have transplantation at all, or the services they have are really bad. And so somebody finds a live donor, and it's like you and your brother, and you go to Delhi to get your transplant. That's not transplant tourism. That's just finding a good transplant center. If you can pay cash for that, that's good on you. The tourism is when you start to do things that bypass laws or violate laws in the countries involved, and that's not accepted. Soliciting deceased donors. So there's this mechanism by which, let's say somebody dies and they have a sister who is on the kidney waiting list. The family can say, her sister's on the kidney waiting list, but is really low down. We want to do a directed donation to her sister. That's actually okay. There's a mechanism for that, and that's allowed. You're naming a recipient for that deceased donor. So it's okay if it's someone you actually know. There are some people who will solicit directed donations. So, there was a classic case in Texas where a family bought a billboard and said, little Joey needs a liver. If your loved one has died, have them direct the liver donation to little Joey, and it works and it happens, but it's super uncool. And this is not like UNOS opposes this, but it's totally legal. Now, if money changes hands, obviously that's illegal. Soliciting live donors is another thing. So there's like matchingdonors.com. You go to a website, you have ESRD, you pay to be part of this website, you post your story, dialysis sucks, I really need a donor. I also am a, white Catholic ping pong player with an interest in sports photography, and then somebody who might want to donate, it's like, hey, I'm a white Catholic ping pong player with an interest in sports photography. I want to donate to this particular person, and they match up and they do a live donation. And this is legal. It's definitely done. It's not particularly favored by UNOS because, as you can imagine, it's a little bit weird. If the donor is paid, that's illegal again. But, we transplant people who meet on matchingdonors.com, and I mean, in fairness, they're really good people who want to donate a kidney, and they want to donate it to somebody whose story they kind of resonated with. And so they go to matchingdonors.com and they resonate with their story and they donate. And, if somebody wants to do a good thing, it's hard to stop them. But it's a little bit weird. Last few things, just a little potpourri on management, infection, blah, blah, blah. Common questions in post-transplant management. Here's one common question. Rapidly dropping urine output after a kidney transplant, usually around day 3. And they say, what should you do? And you should almost always start with a duplex ultrasound. What does the duplex gives you? It gives you this resistive index. And so that gives you a sense of parenchymal resistance. And so if the resistive index is high, that means that, blood is not flowing through there. It may be an ATN of some sort or a really early rejection of some sort. It lets you see the vessels too. Make sure there's no thrombosis. Make sure there's no stenosis or kinking of the vessels, etc. Lets you look for obstruction, like in kidney, that's a ureteral obstruction, in liver, a biliary obstruction, etc. So duplex, that's a good thing and gives you a lot of information. Here's an example question. A 45-year-old woman, 3 months after a kidney transplant with nausea, diarrhea, and abdominal pain. The creatinine's risen from 1.4, which was her nadir, to 2 over the last week. She's on aspirin. Recently treated with a steroid pulse for acute rejection. Current immunosuppression is triples, as we talked about. What's the most appropriate next step? The responses are coming in very slowly because you're like, what the hell is all that information about? So why did I tell you she's on aspirin? Yeah, what happens when you stick a needle in somebody on aspirin? That ain't good, right? I gave you that little hint after all the responses came in. Yeah, so a lot of you want to biopsy her. Don't biopsy somebody on aspirin unless you really, really, really need to know. So 20% of you got this colonoscopy. For somebody who answered colonoscopy, what are you thinking? Infection. That's specific. So you want to stick a colon up their bottom? I mean, a scope up their bottom? That's yeah, CMV, right? So that's what the why is it not hold FK and check the level? So it could be FK toxicity, but she was recently treated for acute rejection, and maybe that steroid pulse didn't work too well. So maybe this is a recurrence of that rejection. You hold the FK, now it'll declare itself. Now you'll know that it's a rejection, right? So that's why I wouldn't particularly do that one. None of you admitted that you didn't pay attention on transplant rotation. Nice, good. But of course, 79% of you were wrong. All right, so always think CMV. When I was going through my transplant fellowship, I had an attending every morning who would say to me, Dory, what are you thinking? And I would have to say CMV because always think CMV in transplant. It's the most common post-transplant viral infection. The symptoms are mild and non-specific. That's why you have to always be thinking about it. Colitis is very common, so fever, mild diarrhea, abdominal pain. Colonoscopy is better than serology at diagnosing this. These, you treat it with ganciclovir or foscarnet. Colectomy is rarely needed for this, although you can get some really, really bad CMV colitis that will require it. Other presentations, leukopenia, pneumonia is a presentation for CMV, et cetera. It's the weird, very prevalent infection that's always hiding around the corner. BK virus, I call it bad for kidneys. Okay, so if you remember BK stands for bad for kidneys, then you'll know everything you need to know. 90% of the population is exposed to BK. It's dormant until you're immunosuppressed. It's common to see BK in the urine. It's less common to see detectable virus in the blood, and it's least common to see actual BK nephropathy. As you walk down that road, most people don't care about virus in the urine, but as you start to see BK in the blood, before you get a bad BK nephropathy, you want to treat. Unfortunately, treatment is not very good. There's not much you can do. There are some antivirals. They don't work very well. You really just have to lower the immunosuppression. If they're doing well, they're not having rejection or whatever, you can get away with lowering it a little bit, but you have to keep watching out. You can't just cut the immunosuppression in half, and then they get a rejection, and now you need to blast them with immunosuppression, which will then allow the BK to run wild and free. Post-transplant malignancy, squamous cell carcinoma is very common post-transplant, most common after a kidney transplant, and is the most common one to show up on the board. So squamous cell carcinoma after transplant. Non-melanoma skin cancer, so that's squamous cell or basal cell. The risk is the duration of immunosuppression, older age, history of actinic keratosis, being male, and outdoor occupations. And the median time to tumor is 3 to 4 years. There are malignancies associated with viruses. And again, whenever there's this kind of association, you can imagine a little question that would say, match the malignancy with the virus. HPV, that's cervical carcinoma. Hep B or C is hepatocellular carcinoma, HCC. HSV8, that's Kaposi's. EBV, that's PTLD. So we went through this question about PTLD. Let's see, maybe you'll answer better this time. Which is true? Which of these lies is true about PTLD? T-cell, Hodgkin's, Rtux, HSV8, usually seen 1 year or more after transplant. You did this before when it was accidentally out of order. But I'm giving you another shot because you sucked at it before. Yeah, nice. You're much better now, probably because you looked it up after you missed it. Non-Hodgkin's B cell. It's associated with EBV. The presentation is non-specific, or they end up in the ER for anything. And what do you get the first the first 5 minutes that you show up in an ER, particularly if you're complicated and you're a transplant patient, you get a CT scan, and then they see this weird stuff on the CT scan. It's usually within the first year post-transplant. The risk is immunosuppression, especially people who got OKT3. It also says especially people who get FK, but everyone gets FK. It is not a good thing. Survival with PTLD is poor. You have to balance immunosuppression, so you have to reduce the immunosuppression so the tumors don't grow, but then obviously you're risking the graft for rejection. Although rituximab, which is this B-cell anti-CD20 antibody, is emerging as a promising treatment. So that would be the potential treatment for PTLD. A little bit about live donor transplantation versus deceased donor transplantation. In kidney, recipients do better with a live donor than a deceased donor. It's a kidney, it's a full kidney, just like a deceased donor, but there's no death physiology associated with it. And so, you're taking it from somebody in whom it was working 5 minutes ago. And so it tends to work very well. It's one of the biggest expansions of the donor pool. The laparoscopic nephrectomy, which was started in 1995 at Johns Hopkins, is just as safe for the donor as the old school open nephrectomy, is no better for the recipient, but is also no worse for the recipient. The death rate from the donor operation we published in JAMA in 2010 is 0.03%, so that might show up on the test. This is a little bit of an old slide, and it says the worry is long-term renal function, and we just published in JAMA last year that there is actually a 27 per 10,000 increased risk of getting kidney failure if you donate versus if you didn't donate. That may make it into the exam, but it probably won't, because I don't think they read that recent of literature. These people are probably reading literature from the 1970s. I swear I'm going to catch up on my journals. I got a big pile on my desk. I'm going to catch up on these things from the 1970s so I can move on to the 1980s. On liver, there's a little bit of controversy. Remember, a deceased donor liver, you get the whole liver. Live donor liver, you only get a part of the liver. Now, liver regenerates, which is sweet, so then the donor and the recipient both end up with a lot of liver, but there's a period of time where it regenerates, and it's never quite perfect, and technically can be a very difficult operation because you got tiny vessels and tiny bile ducts and stuff like that. In general, the old teaching was that recipients do better with a deceased donor than a live donor. There's been some evidence that in the right hands, with the right selection, a live donor can do as well as a deceased donor. But really, if you got liver failure, you want to have a full liver. Except maybe in kids. Kids seem to do quite well with a parent-to-child liver donation. The other issue is that the complications of donating a segment of your liver are higher than donating a kidney, for example, by an order of magnitude. So about 10-fold higher risk of death. There's estimated at about like 40% risk of early complications spanning the whole range, most of them pretty minor. But it's a big operation. It's a much bigger operation than a live kidney donor. Dialysis access, what do you need to know? Fistula has the lowest infection rate and the best flow. Graft has a 10 to 15% lifetime infection rate. And catheter has the highest infection rate, 50% infection rate, and the worst flow. So what you want is from top to bottom here. And there's this Fistula First initiative where they're trying to get everybody who goes on dialysis in the country to have a fistula before having a graft or a catheter. And, the problem is that fistula requires good pre-dialysis care. You need to know that you're in late-stage CKD. You need to prepare for a fistula. It takes time to mature. You need to have access to good medical care. You need to be referred to a surgeon who actually, sort of cares about dialysis access rather than just ramming grafts into people. And so access to fistula is actually relatively low in this country, even though it's the best thing. What are the problems? You can get stenosis of the outflow, which will give you a lot of edema. You can, if you then place a catheter in the outflow vessel, then you can get stenosis from that. People who've had previous catheters and then get a fistula placed on that side can get edema as well. You can get failure of your fistula either from an inadequate venous outflow or an inadequate inflow. Catheter, they should only get a catheter when there's no other option. And I mean no other option. Like people have tried like thigh grafts and, all sorts of other weird. We had a graft in somebody that went axillar to renal vein graft that sort of traveled along the sidewall of their body. So you can do weird things to avoid catheters if there's no other option, or if you just pop one in while you're waiting for a fistula to mature, that's fine also. Right IJ is the best. If you put it in the subclavian, there's that risk of stenosis, which then basically shoots that entire arm out from potential fistula or graft in the future. And that's all I have about transplantation. I'm happy to take questions, and then we should probably take a little break after this because that's a lot of material to handle. So any questions that you want your classmates to hear? So the question is, can I review all the sites that you can do? Yeah, so vascular anastomoses for a kidney transplant. So usually it's the iliacs, right? So you can move up and you can anastomose directly to the aorta. And then other people have done really weird things. We put like a kidney into the lesser sac and like anastomose to whatever vessels we found in that area there. But usually, you know where the kidney incision is going to be, and usually you put it on the iliacs. Some people use the internal iliac and they do an end-to-end, which is kind of weird. Some people use the external and they do end-to-side. Some people go up on the common. It kind of depends on what the anatomy looks like, if they've had previous transplants there, et cetera. I doubt they'll get too much into detail on that, except in general, where's it going to end up? Yeah.
Is there a right versus left preference?
For kidneys, for iliacs? Again, some people prefer the right because the vessels are kind of more toward the surface. Some people prefer the left because if you're using a left kidney, you don't have to swap the artery and the vein sort of geographically. There's really there's no board preference for sure. The outcomes are going to be the same, whichever side you put in. You don't have to match left to left, right to right, et cetera. Yeah.
Just going back to transplant tourism.
Yeah.
You gave an example of someone going to Africa and getting an organ. Is it being transplanted there or back in the U.S.?
Yeah, so transplant tourism, the question was like, if you go and you buy a donor in Africa, is it tourism if you're transplanted in Africa? Is it tourism if you then bring the donor back to the U.S.? It's tourism in either way. And if you go to Africa and you buy a donor and you bring that donor back to the U.S., we hope you'll probably get caught because you're paying somebody to donate. So it's illegal because you're not allowed to buy and sell organs in the U.S. And as a result, because it involved multiple countries, it's considered transplant tourism.
So you're bringing the person, you're not buying the organ and then flying it.
So it's unusual for somebody to buy the organ and then try to get the organ transplanted in some other place. Usually when transplant tourism happens, you go to that country and they have a donor lined up for you and you get the transplant there. Yeah, in the back.
I've seen this in my transplant rotation. Supposedly, after a kidney was transplanted, the patient is taking a tremendous amount of urine, but the creatinine is not dropping.
Yeah.
In that situation, can you consider that the transplant is successful, or is it an indication that the transplant is not going to affect the creatinine persistently?
Yeah, so the question is, post-kidney transplant, robust urine output, but creatinine not yet dropping. So in most cases, we're not transplanting preemptively. So most cases, our patients are anuric before the transplant. So let's assume that you're talking about a scenario where the patient was anuric, now gets the transplant, is making a bunch of urine, but isn't dropping the creatinine yet. Eventually, that creatinine will drop. So it's quite common that you have this initial sort of urine producing stage, but you're still in ATN, and eventually that ATN will resolve and the creatinine will drop as well. It's highly unusual for a kidney to make urine and keep making urine for months and months and months and never drop the creatinine.
So it's not an indication of transplant.
It's not, so creatinine that's not dropping initially with good urine is not an indication that the allograft has failed. It's an indication that you have still some ATN that needs to be resolved, and eventually, yeah. Now, if you require, so technically, if you require dialysis in that first week, not for fluid management, obviously, but for electrolyte management or something like that, that would be considered delayed graft function, DGF, which is defined very strictly as the requirement for dialysis in the first week. But still, that kidney will regain its function.